If we can get to the point where we're actually preventing diagnostic and treatment errors, I think that's the holy grail.
To help set the stage, I'm curious whether you talk to our partners, our users, or even friends and family, how do you tell the story about what is clinical decision support? How is it useful? How does it actually impact both clinical outcomes for the clinician as well as the patient?
When I think about it, I think it's important to talk about what clinicians do now and how this is different. And so I talk about clinicians have to go outside of their workflow, outside of the encounter, outside of the note that's naturally happening in the EHR, and actually give context to our CDS tools to get relevant information. But there's so much out there that we have to really surface the most important stuff. And how do we do that? And so part of that is really giving those tools context of what the patient is, what they're coming in for. And so being able to do that in workflow is really where Abridge comes in and has this really powerful impact for our clinicians, that they don't have to go outside and enter all this additional information. They can really feel comfortable that what they're talking to our CDS tools about is actually going to pull up relevant information for them.
Yeah, I think Griff makes a really good point. As doctors, we're not omniscient. There's hundreds of new papers that are published every day. And when, as a hospitalist, I'm at the bedside next to a patient, I can't digest all of that in an instant. But with, the kind of tools that we're building, I can have that all at my fingertips, at the bedside. And when that patient wants to know, do I need a biopsy for this tumor, before I see oncology, or can the oncologist just see me now? I can look up, does this patient need a biopsy? And then the tool has access to the patient's medical records. It has access to our conversation. It has access to the latest literature, and it can guide me correctly.
I think that's exactly right. I feel like it's not really about more information, because there's so much information out there already. It's really about reducing cognitive load in the key moments that really matters in the clinical workflow. Yeah.
What motivates you though to work on this? It sounds amazing, but what's your journey here, and why did you join?
When we were testing this out, I kept trying to put myself in, back when I was practicing clinically, which I don't do anymore. I know Chase still does, but how would this have really impacted my workflow and my work stream, in addition to reducing cognitive load and burden from an administrative standpoint, which we do from a note perspective really well. This can really reduce our cognitive load from let's look up the relevant information. And so when I was testing this out before it went live, I was just going back to how would I have actually used this as a hospitalist in the hospital, and how would this have really impacted clinical care? And so being able to do that efficiently in workflow, either in real time or immediately after, is really important, because we are constantly overloaded with not only how do we get relevant information, but pages from nurses or patients asking questions. And so any time that we're going outside of that workflow is time that we aren't able to spend with patients, or spend time taking care of patients in the best way. So that's what I was really trying to dive into when I was testing this, was how can I actually test this out and figure out how this would be useful for clinicians across the board, I think is really important.
Were there any specific aha moments when you were trying to put yourself back into your previous shoes?
I think when I was testing out these different queries to CDS, the aha moment was, wow, I don't have to give this additional context. I don't have to say this is a 5-year-old kid with X, Y, and Z diagnosis. It has all of that pulling in. And so I just have to think about the question that I want to ask. And then it's pulling that information for me. And with the sources that we provide, we can always, pull that in and be like, okay, where is this coming from? Let me actually verify this if I need to, but it's all right there in workflow. And then if I need to, I can go back in and really dive into the literature. But having all of that right there is so impactful. And I didn't have that when I was practicing. And I think it would be really cool to go back and actually be able to use that now.
And Chase, it's interesting because you are both practicing as well as building this. So how do you, how has that experience been?
Oh, I joined Abridge basically, to build this for me and people like me. So I'm a little bit biased answering that question, but no, it's been a great experience. And to your previous question, I think that one thing that I like to tell med students and residents is that, you should never spend more than 30 minutes, 45 minutes at a time sitting at a computer in the workroom. If you are, you're doing something wrong. Like, you should be in the patient's room. And we're building technology that makes that actually possible. Like, if you live up to that principle right now without these kind of tools and without this kind of platform, like, it's not a reasonable standard. But we're trying to make that possible.
That's amazing. Sana, what about you? How as you've been discussing with clinicians, even not coming from a clinical background yourself?
Yeah, I think for me, our product is really valuable because it's the perfect alignment between like technology capabilities and real human value. Like, I think it's really not about like launching flashy AI features, but I think it's really about like creating something that's helpful and useful for clinicians. The favorite part of my job is like going on customer calls with our customers, and we get so much love at the end of every call. Even if like there are things that they want that it's on our roadmap that we're about to build, like there's still like things that they want to see our product does. But at the end of the day, they always tell us how much our product made their lives easier. There's like always so much love coming from our users. And I think that deeply motivates me as a product person.
So just diving into that a little bit more. So, one thing I've heard Chai talk about is, how he's almost worried that all our feedback has been positive. Like, Chai, like why does that worry you?
The thing that really worries me is that I am not my own user here. I'm an engineer by training, and I'm really excited about the technology, and I think there's a lot of learnings from general tech that I can bring here to build this product. But if I'm not my own user, I'm always looking for the gap. What is the gap? What are the insights that I don't have? And I think this is why the clinician-in-the-loop model at Abridge is so relevant. How do I know, normally in your workflow you would do this, and if you would do it a certain way, you might never actually use the product because you're actually spending your time with the patient, for example. And so if I don't have those real-world earned insights, I'm always looking for a way to get it, even if I didn't experience it myself.
Yeah, I think that's actually something we do really well at Abridge, and I was really happy to see when I joined it's like the clinician is in the loop everywhere in the company. It's in building, it's in client-facing position, it's in product experience, it's throughout the company, and even our CEO is a practicing cardiologist. Like, the values are there that whatever we're building has to be useful for doctors and has to make their lives better. And because the priority of doctors is the patients, the consequence of that is it also has to be great for patients and making patients' lives better.
Yeah, I can't tell you how many times I go on customer calls and they get really excited, like clinicians at our partners, that we have clinicians that are actively taking feedback from them, but they know that we are also testing and using these features and know the workflows and the burdens that they're experiencing. I think that's just something that is experienced and something that we can connect with them on. And you just see this big relief when kind of you talk about, I'm a clinician, I have this background as a pediatrician, and obviously partial to like working with other pediatricians, but just doctors in general. It's been really cool. And I think Clinician in the Loop really was big for me coming to Abridge, because my second week on the job, I got pulled in to start testing out the CDS tool. Our first week was this big company on-site. I was still doing onboarding trainings and learning Abridge, the product and like the processes here. And then I just created this leaderboard for us, and I started getting pulled into like testing our CDS features in between, trying to do some onboarding videos and testing this on the side. And I think I tried to test it on the weekend. I think on a Sunday, I was like, I need to like up my standing in the leaderboard. I can't be last here. And so while I didn't win, I was not last. And I think that was really cool to be like, they really care about our insight, clinician insight here at this company. And that was just really, really evident like second weekend.
And you kind of gamified clinician.
Yes.
Yeah, what is this leaderboard?
Like, how did you do that?
I think, I learned a few things. One of the biggest takeaway is our clinicians are very, very competitive. They're really good at their job. They're very dedicated, and they're very competitive. Yes, you. So we created this like clinical whispers competition, mainly to like make sure we build confidence on the product quality, both in terms of like the content quality, making sure it's clinically safe, and also making sure the user experience is intuitive and frictionless. So we basically created this like competition group for like over like 10 clinicians who are like our internal clinicians. And then I think it's over the period of 10 days, these like 10 clinicians who all have full-time day job elsewhere, like at the company, issued over like 800 queries to stress test our product. And they weren't just like testing the product, but they were also giving us like super detailed feedback, very high quality, like brainstorming around how to make the product experience better. And I think what made this work really well was our entire builder team, from engineers to PMs to data scientists, were all in this like Slack channel. So we were like in real time triaging issues, like brainstorming things, like implementing in real time. So like, I think just over the course of this 1 week and a half, the product got like a step function better. And then by the end of it, we committed to our March release date because we had gained a lot of confidence in addition to our offline evaluation and also in addition to our early release user feedback. And then on top of that, we had a gamified leadership board where every day we were like ranking our internal clinicians' participation based on the number of queries they've issued, based on the feedback they've given. And we also had a prize at the end. So Griff, right now we have a surprise for you. To thank you for your participation, we want to present you the GOAT trophy. And it says you're the clinical whisperer from our CDS team. And thank you for helping us win.
That's amazing. Thank you.
This is
perfect.
trophy.
Yes.
Congratulations. I want to understand a little better. Like, we had this leaderboard, which was separate from our offline evaluation. And I think there is, as much as we try to get offline evaluation as great as possible, I think there's something about real world feedback that has insight that you can't get through any one given eval set. I was wondering if any of you had examples of such insight, or patterns that you've seen, whether it's from the internal clinicians testing, external, that you could share.
Yeah, so I'm on customer calls, almost every day probably, and we get to showcase these new features to clinician leaders at our partner sites, and we get real-time feedback as we're talking about new features that are coming out, that as we get feedback, we can relay to our product and engineering team really quickly as to, hey, this isn't even out yet, but this is the initial feedback. Maybe here are some concerns that we didn't think about when we were initially testing. We only have so many, and when we go out and actually showcase this to partners across the country at all of our vast kind of partners, we can get their feedback and relay that back. And I think one of the big ones, for me at least, curious to hear your opinion though, was when we first released CDS, our immediate feedback was, this is awesome, but it's after the node has been generated, after the encounter has kind of been almost done in a lot of cases. This would be great if we could push this upstream and before, even during the visit is taking place. And then the next kind of release was, hey, this is now available before and during. So I think just how quickly we iterate and take customer feedback, we know that that's important. We know we are limited on some case, even though we have clinicians in the loop, but actually getting real world feedback is super important. But curious to see what you can take away from that as well.
Yeah, so I totally agree. I think our offline eval, and Chase can share more here, does a really good job making sure we're clinically safe. Our clinical quality is really high. We're grounded in evidence. But I think the part that really needs real world testing is making sure we're embedded in the workflow in the right place. So both making sure it's available at the time people actually use the product, but also in every single EHR system, many organizations customize their EHR workflow. So there's always going to be specialty cases where we see certain edge cases around how the UX flows, how certain buttons are at different places for different organizations. So those we won't be able to tell until we are actually testing it in the real world workflow. And one of the goals for our product is to make sure it fit very seamlessly into the workflow. We're meeting users where they are. So we want to make sure we can address all of those use cases. I think the second theme that I'm learning from real world testing, both with our internal clinicians and external clinicians, are clinicians have very different preferences. So I remember the first week we launched this experience to our internal clinicians. We have Reed, who's another internal clinician, was like, I need this to be a lot more concise. And Chase, our other clinicians here, is like, I love all the details. And I think this happens over time, like a lot over time when we're talking to clinicians. They have a lot of different preferences in terms of styles, tones. So I think like also getting those feedback help us understand the importance of personalization, which is something that we're going to work on, making sure our experience can tailor towards every single clinician's preferences.
Yeah, I think that's a really good point. I mean, we pride ourselves in the rigor of our offline evaluations. We think that we've built evaluations that are actually that actually exceed the quality of any of the published benchmarks. That being said, the subjective user experience is completely separate from the performance on the benchmarks. And I think that's a great example with Reed, who's a emergency medicine doctor. And if you guys know anything about specialty personalities, like as an internist, my expectations for the response are going to be very different than an emergency room doctor. And so, we're trying to build something that makes everyone feel like they're having a good experience and is meeting their needs. And so having that live feedback is critical.
So now I remember in the early days, there was a message you sent in our internal Slack that was like, one of the pieces of feedback I got was the AI sounded too human.
Yes.
I remember reacting question mark because I had no idea what that really meant. Yeah. But I think it's one of those things where one, it's helpful to get the feedback, but then I think we spent much more time with the user and really dug in to get that. And I think the broader point here that I think actually a lot about as an engineer is always like, how do I always optimize feedback loops? So whether that's with our internal testing, external testing, but there's also a feedback loop within the project as well, where the users can create their own feedback loop to improve the product. And I think that's actually one of the directions that excites me the most, technically.
For sure.
I'm curious, Chase, how did your real world clinical experiences actually shape evaluation of the product and the overall product experience?
Yeah, no, that's a great question. So, as a hospitalist, I'm seeing patients who are at the most difficult times in their life, right? They're admitted to the hospital with an acute illness. And it's a privilege to be able to be there with them, while they're going through these things. But, that privilege comes with the responsibility of making sure that we're giving them the absolute best care that we can. And so when I build our evaluations for a platform that's going to be used by doctors in these kind of situations, it's incredibly important to me that the evaluations we put it through are the most rigorous possible. And so we have built an incredible data set, that's grounded in real encounters that looks at clinical safety, clinical quality, and we really put the model through its paces to make sure that it's giving answers that are top quality. And that's meaningful to me personally because I know that this is going to be used in the kind of scenarios that I'm in where doctors are there with their patients and expecting this to be something they can rely on.
What does that actually look like, the process of developing these evaluation sets?
It's not easy, so it takes a lot of work. So Abridge has the privilege of being in the conversation in millions of patient encounters, right? And so, what we've done to create these evaluation sets is we've taken real encounters and we've generated both synthetic and real queries based on those encounters, like questions that doctors might actually ask such a system. And we have 2 independent physicians come up with what would be a golden response to that question. And a 3rd physician adjudicates those 2 golden responses and comes up with a final rubric. And we've done more than 1,000 of those. And we make our model answer all of those questions and we grade them against the adjudicated rubrics. And no one else does evaluations with this degree of both quality and quantity. And so it makes us feel very confident that what we're putting out there is safe and effective.
And I think there's another point there beyond the quality and quantity. It's like we're really creating a product that hasn't existed before. Clinical decision support grounded by evidence during the conversation. And so we had to, I think, create our own evaluation and benchmarks and so forth. And what I think was really great, you made this point, but it's like, it's grounded in like actual real world conversation. We're not just building a benchmark that doesn't actually correlate with reality. Both we're building a benchmark that actually highly correlates with reality, and then we actually have a domain expert in the loop codifying that. What should that evaluation look like? Because one of the things I think about a lot is like, I want to build a product for you, and like I want evaluation to be whatever in some funny way would make Chase happy. Is like kind of the crux of like the gist of all of these many different evaluations and dimensions that we do.
I think that's cool because this is an expectation that clinicians have, that it's going to be rigorously tested, because it's going to be in real world situations where you and I need to make decisions where we maybe don't have all of the information, and we want it to be able to surface the most relevant stuff to us in that moment. And although it's a clinical decision support, it should be supporting our decisions. Ultimately, we also still want it to be rigorously evaluated and know that what it's going to be surfacing is true and accurate, and we can trust that, although we still have verification that we can go through on the back end and actually go through those articles and that information to know that it's just been rigorously tested, you know, in so many different encounters and scenarios, real world and not. That's just something clinicians expect at this point when they're looking through clinical decision support, because we don't sometimes have time to go through it and do that ourselves.
I'm curious, when did you know that we were onto something? When was there or proof that this was working?
I think when we put it in the hands of the first few clinicians, including like external, like the first two, honestly, when I went to talk to the clinician who said it's too human.
Yeah, wow.
Yeah,
okay.
and I think his feedback was like, I'm worried because you built such a great product. I needed to remind me it's not a human. And he's like, because it's so great, I feel that over time, I'm going to rely on it too much. I want you to like change the tone, tweak the style so that it can remind me that this is still like AI and not real human. And obviously we've made a lot of like tone improvement since getting that feedback. But I think it's just like, it really surprised me when we first released it in alpha and early releases, like most of the feedback were overwhelmingly positive. And that's when Chai was very worried about not getting the constructive feedback. So I think that was like the moment I was like, wow, if our V1 is already so helpful, there's just like, and we still have so much we want to do on our roadmap. Like there's such a long backlog of things we want to do, then we're definitely onto something and we can definitely create a lot of real world impact.
I like to think we got into clinical medicine for the ongoing learning. I don't think when we graduate med school or residency, learning is never done. There's always more information and data that's coming out that helps us do our job. And what I see CDS doing is, and how we can maybe help mitigate the automation kind of risk here and bias here, is think about it as a constant learning opportunity to always dig in and understand the research and the literature, which is hard sometimes with limited schedules and time. But if we're able to reduce cognitive load and administrative burden from a node standpoint and from, you know, a task by task standpoint, then maybe we have more time to actually dig in here, look into the CDS tools, and actually research more and make ourselves, you know, more important and more impactful there too.
Yeah, I like that. I think both of you are hinting at a way that doctors actually just have far more leverage with AI, and that's exciting.
Yeah.
Well, last question, what are you looking forward in the near future that you can share?
Particularly with CDS, while we have lots of great partners and we have during visit and before visit, and we have all this patient context that is getting us more information, relevant information when we need it, there are still differences in the way partners practice medicine across the country, different diseases, different disease prevalences that impact the treatment options or the workup, that also just, as we talked about earlier, preferences are just different across health systems. And so how do we get to a point of personalization that goes beyond just surfacing relevant information, but surfacing relevant information that goes to the way that they practice medicine, and getting at like local guidelines and antibiotic kind of resistance and different ways of treating things across the country. I think that's what I'm really excited about, is how do we get more personalized there? I think that's a really exciting kind of exploration.
Yeah, Chai, I mean, I think there's so much more we could do. You know, despite the amazing initial customer feedback, I mean, we even had a primary care doctor say that he now uses CDS on every patient he sees. Like, I think despite the great initial positive feedback, you know, content sources, like we can ingest more high quality content sources, you know, partnerships with specialist societies. I think more proactive clinical decision support. So right now, you know, it's mostly the doctor. We have suggested questions, but it's mostly the doctor prompting the agent. But if we can get to the point where we're actually preventing diagnostic and treatment errors, I think that's the holy grail, where what we're building actually has an impact on, you know, by some estimates is the third or fourth leading cause of death in the country, which is, you know, medical errors, then I think we could make a big difference.
I think +1 to everything they've said. It's all on our roadmap. I think definitely like more context, as you mentioned, like there's like a lot more patient EHR context that we could ingest to make the system even smarter. More content sources, especially the ones that cater specific to an organization, and personalization memory specific to a clinician so that we can cater to each clinician's style and preferences. And then also on top of that, like if we take a broader lens at Abridge's product suite, there's like so many actions that Abridge can do. Like, so we started by clinical decision support and also supporting editing needs. But we also can help clinicians with like placing an order, generating a patient reference letter. There's like a lot of things that we could help clinicians with the goal of reducing their cognitive load and administrative burden. So I think like having a very congruent experience inside Abridge AI could really help with that.
What about you, Chai? What do you think? What are you excited about for the future?
All of that, of course. But if I'm thinking very futuristic out, I'm imagining some world in which you've got clinical decision support that's connecting from when the patient's at home all the way. That same context, you know, we've talked about the importance of context, but there are so many more layers to context, from the patient's first thinking whether or not they should visit the hospital or not, connecting that, providing that to the clinician, augmenting it with, of course, you know, other vital signs of the patient. You could imagine biometric tracking, so many other things that you could do over time. And then like in a way that it's actually, clinical decision support isn't a thing you go to, but it's more this, one of the things we talk a lot about at Abridge is like this air conditioning, something in the background, but it's something that's kind of always there and seamlessly connecting all this context together with the one end goal of delivering the best and greatest patient value, both at high quality, but also as soon as you possibly can throughout that entire patient journey. So how do we bridge all of that is really exciting to me. So one of the things that I'm curious about is, so you mentioned earlier, like one of the like first aha moments for you is when you actually talked to that first clinician and you knew we were onto something. Since then, some few months after that, we actually made this product generally available to entirety of Abridge's, you know, customer base, which is 250 plus hospital systems, covers a wide variety of settings and specialties. Would love to learn any lessons from the launch. How did the launch go? What can you share?
I think we saw like a hockey stick growth in our weekly active users, and that was like really exciting for the team. And we've continued to see like very strong engagement, really strong like 7-day retention, which is a metric that I personally care a lot about because I think it alludes to users not just trying it for novelty effect, but actually finding value so that they come back within the next 7 days to use it.
And this is across all specialties, right? And like different care settings, like
across all specialties and all care settings at Abridge.
Great.
Yeah.
Cool. Thank you so much for spending the time.
Thank you.
Always love hanging out with y'all.
Yeah.
You're a great interviewer.
yeah, that was fun.